what we know about this.
Thanks, Tony. I am sure that you will all leave here knowing exactly what to do in all situations. No, I appreciate the invitation and the nice introduction. Like Tony mentioned, I chose this topic because this is a real clinical interest of mine, and there have been some recent developments in the literature that I felt were really prominent and important to kind of bring up to the group and to discuss, because this is, again, another one of those gray areas of medicine that we really struggle with, in particular in this population of newborn infants who are premature and have a very different physiology from term infants or certainly older children or adults. So hopefully what I can do today is kind of frame some of the questions, the two main questions that come up a lot in the neonatal intensive care unit with these children, and give you some background and data as to what might be happening in these infants, what we should be doing now, and in the future, what future studies might help us with in determining the best course of therapy. So I have no disclosures. And the learning objectives for today are to be able to contrast the functionality of the premature and term infant's thyroid gland and the levels of thyroid-specific hormones. I think that when you're dealing with potential problems in thyroid function, you have to know what are the norms or what would you expect to occur in different gestational ages. And then to discuss the association between neurodevelopmental outcomes, specifically cerebral palsy, motor impairment, cognitive problems, and low levels of thyroid hormones in this population. Lastly, we'll talk a little bit more about the rationale for repeat screening of repeat newborn screening for congenital hypothyroidism in the neonatal intensive care unit, why we do that and why it is or why it is not important. So just as a bit of background, we've really come a long way in neonatal care. Back in the 1960s, the most extreme premature infants, most of those infants died, and they died from respiratory disease, they died from infection, and their survival rates were really right around 5%. And with the advent of major advances like surfactant, or wonderful neonatologists, and the care that these children now receive, most of these extremely premature infants who are 24 to 28 weeks gestation will survive, so close to an 80% survival rate. And even those that are younger than that have a 50% survival rate. So we've really made incredible strides here. On the other hand, we also have higher rates now of these children who are going on to survive with neurocognitive problems, including cerebral palsy. So 1 in 8 will have cerebral palsy or some other type of neurodevelopmental problem. And if you look at the annual birth rate of children in this gestational age, there's about 20,000 infants born per year just in the United States alone. So this is a significant problem that we are all facing as pediatricians. So when you look at this data, we have to ask ourselves, are there additional factors that might be modified during the course of these infants' clinical care or their courses in the NICU to improve upon these outcomes? And specifically, could what we know about thyroid hormone and its role in neuronal migration, cognitive development, be the key factor and something that we could modify for these infants? So let me take you through a case. This is a made-up case, 25 and 2/7-week gestation, 850-gram infant. He was born, had respiratory distress syndrome, was intubated, received surfactant, has a grade 2 intraventricular hemorrhage. And the prenatal course was marked by intrauterine growth retardation. The infant's initial newborn screen was normal. I don't know, they have preemie babies on Wikipedia too that you can steal the pictures from. The thyroid levels were obtained. It could be for a number of reasons, but you know, thyroid levels, we get thyroid levels all the time. So at 1 week of life, this is this infant's thyroid levels. TSH 2.88, free T4 0.7 nanograms per deciliter, and a total T4 of 3.6 micrograms per deciliter. So these would be flagged as, these T4 levels as being low by the normal reference range, and the TSH level being normal. So what might be affecting this infant's thyroid status? And should we be thinking at all about giving this baby thyroid hormone? All right, so this picture has nothing to do with neonatal thyroid disease, but I thought it was a really amazing picture, something we don't see very often. So this is a lingual thyroid gland that you can actually see when you look down the back of somebody's throat. It's quite large, and it's a reminder of two things. One is that I am not going to be discussing primary congenital hypothyroidism, where there is a defect in thyroid gland embryology or the way it actually produces hormone, like dyshormonegenesis, and also to remind us that the thyroid gland forms at the base of the tongue, the pharyngeal floor, and then migrates down to the front part of the neck. So when you have failures of migration of the thyroid gland, sometimes you end up with lingual thyroid glands, and this one is particularly large. So why is it important that it migrates to the right place? Well, thyroid hormone has a number of very important effects during the neonatal period. Probably, arguably most important is its effect in neurogenesis. So there are effects on neuronal migration, myelination, axonal development, effects in the synapses, neurotransmitter development. And these are all very important for the normal development of the infant's brain. It also has important effects in thermogenesis, and particularly in brown adipose tissue. So thyroid hormone is important for helping this infant maintain body temperature. It has effects in the hepatic enzyme, skin maturation, at least in fetal rat studies, bone and hair growth, cardiac. There's certainly evidence for roles in PDA closure and other important cardiac effects. We know that thyroid problems often accompany cardiac defects, and we'll come back to that in a second. And certainly an important role in lung maturation, and that comes from fetal sheep data. So it has an important component to surfactant production and lung maturation. So these milestones in thyroid gland embryology and how it forms are really important when we're considering problems in thyroid function tests or in these infants. So at 2 weeks, the median enlarge forms. At 6 to 7 weeks, the lateral components of the thyroid gland and all these things will fit together down in the anterior portion of the neck. These begin to fuse with the median portion, and there's actually detectable thyroglobulin synthesis. So there's a bit of protein production that begins to occur at this young age. At 8 to 10 weeks, the gland is able to start trapping iodine for production of thyroid hormone. And then just a few weeks later, there is detectable levels of T3, T4 from the fetal thyroid gland. So really at 12 weeks, that gland can actually start making a little bit of thyroid hormone. But it's not really till after this time frame that the connections between the hypothalamus, the pituitary, and the thyroid gland start to emerge. And truly that this negative feedback loop that we're all very familiar with is not really functional until close to 28 weeks or so. And this becomes very relevant when we're starting to think about 24, 25-week gestational age infants that are born. Perhaps most importantly is that up until that point in time, maternal thyroid hormone plays a very important role in providing a small amount of thyroid to this infant. So again, when we think about infants that are born 23, 24, 25 weeks, that flow of thyroid hormone to the fetus is disrupted, and now we have an infant who is no longer has the ability to depend on that flow of thyroid hormone. So this just gives you a little bit of a graphic description of what's happening between the fetus and mom. I will point out just a couple of things here that I think are particularly important. Here is mom's T4 levels, and these are generally much higher during pregnancy due to the higher levels of maternal estrogens. These will raise up thyroid binding globulin levels, so you get higher levels of T4. Most of the T4 that hits the placenta is actually deactivated, if you will, or converted to reverse T3, which is inactive. And this is done by an enzyme that resides within the placenta called deiodinase 3. This is a really important enzyme. We're going to come back to this in a second. But a small amount makes it through as T4. And this small amount of T4 is very important for the fetus in its development. The fetus has other deiodinase activity that's very important for intracellular conversion of T4 to T3 that are upregulated, so that even with small amounts of thyroid hormone, enough thyroid hormone can be available to the brain for normal development. So this small amount of maternal hormone is very important. So here's this enzyme deiodinase 3, and what it does is that it takes the thyroxine protein, which has 4 iodines on the molecule, and it clips off this inner ring iodine, and that converts it to reverse T3. This hormone is much higher in much higher levels, not only in the placenta, but also in the fetus throughout the first and second trimesters. Those levels start going down towards the third trimester, but its levels are very high during the other parts of the gestation. Alternatively, monodeiodinase 1, which is what typically converts T4 to T3, the active form of hormone that binds to its receptor, are very low. Levels are about 24% of what you would expect to see in an adult population. So that's very low. This monodeiodinase 2 is the one that's actually upregulated a bit, has higher levels, in particular in the brain of the fetus, and that again allows for conversion of small amounts of T4 to T3 in the intracellular component. So throughout gestation, there is a gradual maturation of this hypothalamic pituitary thyroid axis that I mentioned before. And that's illustrated by this graph here. And I'll point out a couple things. So this dotted line represents TSH levels in the pituitary, TSH levels in the serum. And you can see these slowly increase throughout the gestation until term, when we see a nice little surge that occurs from exposure to the cold environment and cutting of the cord. So that's our little neonatal surge. And then levels begin to fall back down to what we typically think of as being normal by about a month of age. Similarly, TRH levels will slowly start increasing over time, which is represented by this dot here. The pituitary gland of the fetus will start responding to TRH at about 28 weeks. Until that point, that axis is very immature, so it can't really mount much of a response during then. So this is the age range represented by the shaded box that we're typically talking about in infants in this, who have this particular problem. So again, we talked about pituitary hormones. Here's what happens with your thyroid hormones. So let me illustrate a couple things. Here's your T3, the most active form of thyroid hormone. Very low levels between 20 and 30 weeks of gestation. You can see how low they are. Much of that is because of that deiodinase 3 that's converting T4 to reverse T3, and you can see those levels, they're quite high throughout gestation up until 30 weeks, and then they start to fall. Similarly, T4 levels will be very, very low. Again, right out through here, they're still low until you get to term, then you get a little spike with your neonatal surge. So the take-home point here is T3 levels are low, T4 levels are low. They slowly increase during gestation, but don't really get all the way back up to what you would expect until closer to term. Reverse T3 levels are higher. There are other inactive forms of the hormone, these sulfated forms, T4S, which are also on the high side during the first part of pregnancy. So what might affect the gland, the thyroid function in a premature infant? Well, once they're born, as we've just demonstrated, they clearly have immature hypothalamic pituitary thyroid axis. They can't mount the same type of response that a term infant might. So this might certainly have effects on their function. They have an immature type 1 deiodinase activity, which I talked to you about before. That matures throughout the rest of pregnancy, through the rest of the gestation, to convert T4 to T3. But in a 24-weeker, that is very immature. You lose that maternal transfer of T4. Premature infants have a relative iodine deficiency. Not as big of a problem in the United States, but in areas where it's endemic, this is a significant problem in any premature infant that's born. And the glands are still very small in premature infants, obviously. So their reserves and their ability to mount more of a response is very limited. Plus, typically with these infants, we have other problems in the NICU, right? They're usually sick, they have RDS, they have sepsis, they have neck. So all of these things can also affect how that thyroid axis is functioning. So what actually happens? We sort of talked about what happens in gestation. Now we have an infant that's actually born and what happens to them. So this first slide on the left, which is an old study by Del Fisher from the 80s, kind of shows you the differences in what you see between a term infant and a premature infant. So this first part is your TSH surge, and here's the solid line, shows you a term infant. You get this nice big spike. And in a 31 week to 33 weeks, which is what this study was done on, well, you get a little bit of a surge. You have some evidence that that axis is functioning, but it's blunted. And as you get younger and younger, that blunting is more significant. Similarly, your T4 levels right after birth, higher in a term infant, lower in a premature infant. And again, this is 31 to 33 weeks. There is also effects on how well that baby is. Do they have other accompanying problems? So again, TSH levels, here's your full term infant. Here's your premature infant who's well, doesn't have other problems. And here's your same gestational age, but has other medical problems going on. So that blunting occurs as a function of not only prematurity, but other comorbid problems that may be occurring at that same time. Which really leads us to this issue, and the problem that I brought up with the case, which is THOP, transient hypothyroxinemia of prematurity. And this really describes a pattern that's observed in extremely premature infants, usually about 1 week of age, which is really during a critical time of brain development for them, where you see these very low levels of particularly total T4. When you measure them, they tend to be even less than what you would see from cord measurements if you checked cord levels on those same infants. And the TSH levels during that time are quote-unquote normal, all right? So they would come back in a normal range. They're not elevated. Now, how you define this, there's not a universally accepted definition. It's been something that's been observed for the past 30 years, but as you can imagine, assays have changed over time, how you measure T4 or free T4 levels. What you define as being low in that infant could be related to standard deviations. It could be related to how they compare to cord measurements. So there's been a lot of debate about that. But what you can see from the graph here is that certainly as a function of your gestational age, the levels tend to be lower the younger gestational age that you are. So the risk factors for developing this particular pattern of thyroid function tests: earlier gestational age, problems in utero, uterine growth retardation, or placental insufficiency, infants that have asphyxia at the time of delivery, infants that do go on to develop lung problems, respiratory distress syndrome, and who need ventilation or become hypotensive. So these are the sick infants, need dopamine. These are the infants that we tend to see this type of pattern. So obviously, people noticed this, and they started thinking, well, why are these T4 levels going so low? And maybe, since sometimes with these infants that make it through the NICU, and they're having CP and neurocognitive problems, well, those sort of sound like thyroid issues, so let's actually see if there is an association between these low T4 levels and some of these neurocognitive outcomes. So I chose just to highlight one study, and I'll mention a few other ones. And this is a study from the New England Journal in 1996. It was a retrospective review of 463 low birth weight infants younger than 33 weeks of age. And in the study, they compared the T4 levels during the first week of life, which were measured in all these infants, to neurologic outcomes like cerebral palsy, mental developmental scores at 2 years of age in those infants that survived. And how they categorized infants as being hypothyroxinemic were that they had to have, if they were severe, if they had T4 levels that were greater than 2.6 standard deviations below the accepted mean that had been established from other studies, or mild if they were 1.3 to 2.6 standard deviations below that mean. So of this cohort of infants that they followed, 40% were categorized as severe, and about 40% of the youngest 23-weekers were severe. 10% of the 28-week infants were severe. And when they looked at the prevalence of CP at 2 years of age and adjusted for their gestational age, a number of different perinatal and prenatal outcomes, early and late neonatal variables, what they found was about a 4-fold increase of disabling cerebral palsy in the group that were categorized as severe hypothyroxinemia. No real effect on the infants that had milder hypothyroxinemia. And mental developmental scores, there was about a 7-point reduction in MDI scores in those infants that had the most severe forms of hypothyroxinemia. So this is one of the first studies that really brought this issue up and connected these two things when controlling for other confounders that may have also played a role in some of these outcomes. So others have also looked at this problem. This is a study that was, these are from a placebo arm of a study that was looking at effects of hydrocortisone and T4 on lung development. So none of these infants that are depicted here received treatment. These are all placebo arms. And each one of these quartiles here, or each one of these squares, this one is T3 levels here, this one is free T3, total T3, free T4, and total T4. And they were looking at, is there a relationship between the quintiles of T3 and T4 measurements and the number of infants that actually died or were ventilated. And you can see that there's a pretty clear trend between the percentage of infants that ended up dying or were requiring ventilation and either one of these thyroid hormone measurements. Now, there have been several other studies that have found this link. So again, another study that found lower scores on Bayley Developmental Index at 18 months, developmental delays at 2, 5, and 9 years from a couple different studies. Intraventricular hemorrhages were higher, as was mortality rates. Prolonged oxygen supplementation and mechanical ventilation, length of hospital stay, cerebral white matter echolucencies in infants with low levels of T4. And then most recently, lower scores on cognitive and the verbal portion of the McCarthy scale in 5.5-year-old children that were follow-ups from the NICU. So it's fairly well established that there seems to be an association between the lowest levels of T4 levels and some of these neurocognitive outcomes. The problem with many of these studies is that many of them are retrospective in nature. There's different definitions for what categorized as low T4 levels, so they're hard to actually make parallel across the board, but clearly there is an association here. So the next question that was asked is really, well, is this transient low levels of T4 levels, is it the cause of all these problems, or is this just merely an effect of these infants' neonatal morbidity? And are the outcomes improved if you give these infants thyroid hormone? So again, I'm going to focus on one study in particular, which has generated the most controversy in the literature. And this is the Van Wassenaar study that was published back in the New England Journal in 1997. This was a randomized, double-blind, placebo-controlled trial of T4 at 8 micrograms per kilogram per day for 6 weeks in infants that were younger than 30 weeks gestation. And these infants were all matched for variables like gender, weight, gestational age, socioeconomic characteristics, and various pre, peri, and postnatal characteristics. And the outcome measures that they wanted to look at were mortality rates, various measurements of morbidity in the NICU, and then there are also plans to follow them up at 2 years and see what their neurodevelopmental outcomes were. So this is some of the clinical data that was generated from this study, and there were 100 infants in both arms of the study. So this was the largest study that was done. Most of the other studies were much smaller in number. And the only thing that's really worth mentioning here, there was about a 1/3 reduction in a number of deaths between placebo and the thyroxine groups. However, this was not statistically significant. And these other measurements, none of these other measurements looking at supplemental oxygen, PDAs, sepsis, cerebral hemorrhage, all these things, none of these were different between the two groups. And they clearly demonstrated that the infants that got T4 had higher levels of free T4 throughout the length of the study. You can see how these two squared off. This is the classic hypothyroxinemia of prematurity at a week. So there were definitely differences in the T4 levels that occurred in these infants. And when you come out here to the neurodevelopmental outcomes at 2 years, and those infants that survived really didn't find any differences between the two groups at all. So maybe it doesn't really do anything. Well, now what's generated a lot of controversy is that these authors went back, and we do with many studies that are big multi-center placebo-controlled trials, is that they did some additional analyses and subgroup analyses, post hoc analyses, and parsed the infants out into 25 to 26-week-old infants and 27 to 29-week-old infants. And when they did that, obviously the numbers went down pretty substantially. The study was not powered to look at these specific gestational ages. Nevertheless, they found that the youngest infants who were treated had mental developmental scores that were 18 points higher than the placebo group. But when you looked at the older infants, well, now the ones that were treated actually had worse outcomes than the placebo-treated group. The placebos actually did a little bit better. So they actually continued following this same cohort of patients. They did an amazing 99% follow-up at 5 years with these children. And they looked at additional areas: cognitive functioning, behavioral assessments, both from parents and teachers, motor outcomes, and neurologic outcomes. And again, when they looked at the groups as two major groups, they didn't find any differences in these outcome variables. But when they parsed it down into their same gestational age categories, there were a few things that kind of emerged once again. So IQ testing between placebo and T4 treated groups, and they highlight that there's a trend here between the treated group, which are the black bars, and the placebo group, but it's not statistically significant. But again, in the oldest age groups, 29, so now they're really going down to just a single week. So 29-week infants, and you can see the numbers, they're a lot lower. The oldest group, kids, the placebo group did better. They had higher IQ scores. I told you these groups were matched for socioeconomic classes and status, not for the post hoc analysis. So that's certainly a confounder here. Rates of cerebral palsy at 5 years, no differences between them. Again, they point out trends here, but there's really no significant differences. They found some subtle differences in movement scores, these movement ABC scores, which are measurements of dexterity and a few other things. When they looked at all of the kids in the groups, what they found is that the kids with the lowest levels of free T4, irrespective of whether you're treated or not, they had the worst scores, which is actually a higher number for this index. They had the worst scores compared to the middle group, and the kids that did best had the highest levels of free T4 levels. They've also done reanalysis of the entire cohort, looking at whether the free T4 levels, if you just look at those, and specifically the highest 25% and the lowest 25%, were there differences, again, in mortality, and that they found in the placebo group that of the children that received placebo, the highest 75% were associated with statistically significant improvement in neurocognitive motor outcomes at 2 years, but some of these differences went away at 5 years. And amongst the treated group, really they didn't find any differences between the two groups. Now, I'm going to go through all of these, but there have been other, I focused on these two. These are the most prominent ones, the largest studies, but there have been a number of other smaller studies that have looked at T4 supplementation in this group at various gestational ages. And I highlighted the primary outcomes here, and I can summarize for you that all of these studies did not show really differences in outcomes, in the primary outcomes between treated and untreated groups. So, what's a neonatologist to do? Yeah, I thought this was an interesting study. So somebody surveyed about 100 U.S. neonatologists, and they got a response rate about of 79, which is quite good. And about a third of them ever reported treating for these low levels of thyroid hormone at a week of age. 20 of them consistently treated these patients for the past year, so that's their policy, and they treat them. They all used T4 rather than T3. The mean age that they began treatment was about 13 to 25 days, and they all called in the big gun endocrinologist to help with that decision. So we could say, well, I don't really know, but you could if you wanted to. So I think this really shows you that it remains somewhat of a gray area. And I think the studies that are coming up now are addressing some of these issues that we're still kind of struggling with, which are, is there harm in actually administering thyroid hormone to infants that are less than 27 weeks? There hasn't been any evidence to suggest that they're being harmed. Maybe the older infants from the Van Wassenaar study, may have done worse by getting thyroxine. But what about these youngest infants? It sort of makes sense when you think about the physiology and the changes that are occurring in those infants. Should the treatment decisions be based on ranges or cutoffs of free T4 levels for these specific gestational ages, or should there be a universal dose for these infants? And is there a fixed dose that's appropriate for all premature infants? Does it need to be adjusted, and should it be administered continuously rather than a single dose where you have higher levels that then go down? So there is a trial going on right now in less than 28-week infants. This is a trial that's going on in New York, and they are randomizing 144 infants to treatment for 42 days in one of 6 groups, either receiving T4 continuously or by bolus with T3, continuous or bolus T4 at a higher dose with T3, simple oral iodine to supplement the infant, or placebo. And the goal really is to raise the free T4 levels but not suppress TSH levels, which none of the other studies have been able to demonstrate. And the authors of this study feel like that's actually a very important piece to figuring out this puzzle and not over-suppressing these infants by giving them too much thyroid hormone. So thus far, all the data is not published. They have some preliminary data out. And thus far, they've found that the infants receiving continuous 4 micrograms per kilogram per day, so this is actually as like a drip for a while, and then with each feed, that amount, they achieved higher levels of free T4s without suppression in their TSH. So they felt like this is the best dose to use. They've also decided that giving T3 is not necessary, that it suppresses all of their axes. And thus far, the very preliminary, I don't even think it's worth mentioning, but short-term decreased rates of ventilation and retinopathy in the treated groups. We'll see what happens with that one. There's also another trial going on called the Tippet study, which is, again, focusing on this youngest age premature infants. And I think this one is noteworthy. This is going on in the UK because the primary outcome that they're looking at are changes in head ultrasounds. So the arachnoid spaces, brain growth in, this is a placebo versus treated T4 group. There's about 150 infants that are being enrolled there. They're also doing MRI studies. So this is really looking at actually anatomical differences or anatomical changes amongst these infants. So to summarize some of these findings, thyroid hormone physiology is very different in the premature infant, highlighted by an immature hypothalamic pituitary thyroidal axis, low T4 and T3 levels, higher reverse T3 levels, and blunted TSH surge. Extremely premature infants and those who are more critically ill with things like respiratory distress syndrome, hypotension, IVH, have the lowest T4 levels at 1 week, consistent with this pattern, which is transient hypothyroxinemia of prematurity. There's a clear association that occurs between these infants and acute comorbidities, mortality, and worse neurodevelopmental outcomes. But causality is not clear at this point in time. And presently, there's no evidence for universal or targeted supplementation for premature infants who have the lowest free T4 levels. But I think that consideration should be made in those infants exposed to agents known to affect thyroid function. So are there iatrogenic things that we're doing that might also be affecting or inhibiting their ability, things like treating them with dopamine. So I think there are situations where these infants should be considered to be treated. So back to the case for a minute, because there's another element of this story that I wanted to impress upon you. So this is our same infant. He's now 17 days old, and we've decided, because we practice evidence-based medicine here, that we're not going to treat this infant because there's not strong evidence to put him on T4. So he gets a repeat newborn screen as part of the policy here, which is for all infants under 1,800 grams. They get one at day of life 1, and then 14 days, 30 days, and 90 days after any transfusions that they received. And the second newborn screen comes back positive. Does this sound familiar? Anyone? Heard this before, right? So you get thyroid levels, and the TSH is 18. But the free T4 levels come up from where it was before, 1.1. So, well, why repeat this newborn screen? I mean, certainly there are other elements in the newborn screen, but in particular for thyroid, why should we repeat this? And why all of a sudden has this infant's pattern changed this way to a TSH level that all makes us very uncomfortable, right? We feel like, we should treat that, it's 18. So this pattern, which was summarized as atypical hypothyroidism, really been recognized since the 90s. And it's really a late surge of TSH in these very low birth weight infants. So this is data from the Massachusetts back in 93 to 96, okay? And they went back and looked through all their newborn screens, these very low birth weight infants, and found infants that, 10 infants, and here's their birth weights, the days that they had the screen done, their total T4 levels, which are in nanomoles per liter, which none of us are familiar with, but these levels are all low, as you would expect from what you've learned so far. And their TSH levels. Now, the units are a little bit different, but it's pretty close to what we would typically see, or what we would consider for TSH levels in our newborns. And these were all deemed to be normal or borderline. Okay? Now, several of these infants had repeat screens done between 2 and 4 weeks. And I highlighted here what happened to the TSH levels. And look at the magnitude that these things have increased. Very, very elevated. Okay? And so they did confirmatory tests on some of these infants. 2 of them actually started coming down again, which is noteworthy. We'll talk about why that might be. But a lot of them were maintained. So these weren't falsely elevated tests. We did a couple tests in a row, they were elevated. So clearly there is this pattern in these very low birth weight infants. Now this is more data from Rhode Island. And again, this is from 89 to 2002, very low birth weight infants who had greater than 1 screen done, who had a TSH of greater than 15. And the subsequent screen, 91% had TSH levels over, who had elevated TSH levels. 91% of them were over 40. So these aren't sort of borderline second newborn screens. These are all like magnitudes higher than what we would feel comfortable with, right? 40 would be like we would be treating all of those infants. And you can see that demonstrated here on this graph. TSH levels, 50, 100, 150. A lot of these infants, very, very high. When they look back on the records, 23% of these infants who were categorized as having these positive second newborn screens, a quarter of them had some exposure to topical iodine, and 45% of them had associated cardiac defects. Remember we talked about effects of thyroid and cardiac? So interesting findings. Another study that was more recently published by Wu found that in their review of newborn screening results, that over half of the infants that showed the same kind of pattern were also treated with dopamine. So these 2 factors may have a particular effect or influence on these late TSHs. And this is not all infants. This is clearly occurs more frequently in the more premature infants. So this is again from the Wu article. Again, Rhode Island infants, they looked at all the newborn screens from 2000 2006, and they parsed out the very low birth weight infants versus the term infants. You can see the incidence here. Okay, almost 2% of the very low ones, less than 1,000 grams, had this delayed TSH surge. And the incidence gets less and less as the infants have higher and higher birth weights. So the term ones or higher birth weight ones, very, very infrequent that occurs. So this is clearly a pattern that occurs in these youngest premature or very low birth weight. Now, not everybody has really gotten too excited about this. So there's been a couple studies that have looked at, well, what does this really mean? So there, in a study that came from the UK, 5 of 2,000 premature infants had a positive second screen, TSH greater than 6, when they had a normal first one, which is about 1 in 400, about what we've been seeing in most of the other studies. And they had a follow-up test in 4 of 5 of them. And the follow-up test immediately done right after that actually had trended down and was back into a normal range. So this is somewhere between 1 week and 2 weeks after that. So it seemed to normalize. And the 5th one still had a TSH that was elevated, but the T4 was quite normal. So they really felt like, meh. They all kind of normalize. It's transient. What's the big deal? If we changed the threshold and made it a TSH of 8, this would never be a problem. It would miss one true case of disease that they found, so they pointed that out. Similarly, this is a study from Quebec's much lower numbers. Only one of the 465 very low birth weight infants that they screened had a positive second newborn screen, whereas the first one was negative. And this resolved 13 days later. All of the cases of permanent congenital hypothyroidism from this series were identified on the very first screen. So their point was that real cases of thyroid disease occur in that you'll see it in that first one. Now, there are problems with when these newborn screens were done. Some of them were very late, and it was small numbers, and that's been pointed out in the literature as well. So this is the most recent data, again, from that Wu article. They found from those Rhode Island infants, 19 extremely low birth weight or very low birth weight infants diagnosed at a mean of 22 days who had this pattern. 16 of the 19 had resolution of abnormalities in a mean day of 55 days without any treatment. So they just followed them, and they didn't treat them. And it went away in most of them. And they followed these kids out at 18 months, did some Bailey Developmental Index on them. Unfortunately, they didn't have as high a number, so only about half of them came back. But they couldn't demonstrate any differences in Bailey developmental testing between this cohort of kids and a reference population. The only difference that they found was that the head circumference, number of kids who had a head circumference less than 10 percentile were higher in these kids who had this transient hypothyroidism. So to summarize this part of the discussion, late onset or atypical primary hypothyroidism is reasonably common among extremely low birth weight or extremely premature infants compared to term infants. My feeling, iatrogenic etiologies, dopamine, steroids, which can give you a very similar pattern to dopamine, iodine exposure may account for many of these cases, along with an immature hypothalamic pituitary axis since they are so young. And again, the idea behind dopamine and steroids, it suppresses the axis, and as the babies get older, there's a rebound of TSH, so sort of recovery. The majority of these cases are transient in nature without evidence for neurodevelopmental compromise, but some of these cases may be permanent, and as you saw from some of the data that I presented, some of them presented with very high TSH levels. And I think that if you had a child that had some type of surgery, they had high levels of topical iodine exposure, which we know puts them at risk for developing primary hypothyroidism, those infants absolutely should be treated through that period of time and then weaned off of thyroid hormone if need be. So hopefully I've been able to kind of frame this question for you a little bit better. It's a very difficult area, but it is something that's very common in our neonatal intensive care units, and I think that the outcomes of these additional studies really targeting this youngest ages that we deal with, 23 to 28 weeks, are going to be very prominent, and I hope is more clarifying for the best ways to treat these kids in the years to come. So thank you so much for your attention. We got some time, so I'm happy to take questions. Yes, Dr. Johnson.
Brandon, how does the terminology of sick euthyroid fit into this?
Yeah. Excellent question. Sick euthyroid is certainly part of this discussion. So sick euthyroid really refers to the pattern that's seen amongst individuals, both adults and kids, that are in an intensive care unit typically the most ill patients who have sepsis, who are on ventilated, and it's thought to be an adaptive response to the illness that's going on. So what you typically see are low to normal levels of T3, low TSH levels, low normal T4 levels. The available literature on sick euthyroid is that those individuals, whether they're adults or pediatric patients, do not need to be treated. There isn't a lot of strong evidence to say that if you treat them, it's harmful either. I think the same holds true for this population of infants, and that's clearly part of one of the factors that causes this problem. We know the risk factors, they're all things that would typically cause sick euthyroid syndrome. The problem with parsing that out is that they all have, whether they're sick or not, they all have higher levels of this deiodinase 3, which is really the enzyme that's upregulated in that situation and causes higher levels of reverse T3. So sometimes we'll measure that in these infants, and they all have high levels of reverse T3. Now, is that just because that's what their normal physiology is right now, or because they're sick? It's hard to know. Again, I don't think that having that as an element of their course necessarily precludes them from being treated for it. There just isn't a long strata of evidence that individuals who have that should be treated or it improves outcomes. Is that different if it's a 25 or 26-week infant? I think time will tell. Yes, Dr. Georgiev.
Okay, so we'll keep consulting you guys. I think the sad thing is the neonatal fellows and young faculty still have to know this stuff for their boards.
Yeah.
As difficult as it was when I took my boards. That's a great summary. I want to make a couple comments.
Yep.
One is developmental outcomes. And as the audience saw, these are all, other than 5-year studies, which I think you finally can get into some reasonable assessments. An 18-month Bailey, 22-month Bailey, which is typical of the NICHD network where some of these studies come from, is a very short endpoint. It's certainly not an outcome. It's cognitive outcomes are highly dependent on motor abilities. So that's why you may not be able to tease out motor versus cognitive effects. The field of developmental neuroscience and behavioral neuroscience is going more toward targeted assessments, which isn't going to be able to be done in big trials, but to say, okay, if the pathology is on myelin, then how about looking at ABRs, or how about looking at ERPs, or something like that to assess speed of processing? If it's synaptogenesis, which you also talked about, and because of a critical period for that, then what areas and what behavioral tests map onto that? And there, I think you might be able to tease out these effects a little bit better. It looked like, I thought where you were going early with this, and I'd never seen the less than 26-week data versus the 27 to 29 week, that there may be critical periods.
Yeah.
We don't typically think of this being quite that short, but that something is going on, some transition that's going on there, and just more specific developmental tests are going, more brain-specific developmental tests, I think, might tease that out.
Yeah, I think that's an excellent point, Mike. I think what we've learned to this point is that when you group them together, the current measurements that we have and the ways to evaluate these problems maybe isn't sensitive enough to tease these things out. And that there does appear to be maybe a signal in this youngest age, and which kind of makes sense, again, if you think about what's happening with their physiology normally. They are more dependent on that maternal source of T4. They do have a more immature axis. Maybe that small amount of thyroid hormone is going to be important to preventing some of these outcomes, and we should be targeting the specific measurements. And hopefully they'll be doing that in some of these newer trials that are coming out, which are really just looking just at this segment of the population. It seems to me that the world of hypothyroxinemia in general has essentially accepted that if you're 29 weeks or over, we shouldn't be treating those kids. I don't know if that's the right thing to do because it's based on this post hoc analysis from the von Wassenaar study. But I think the group that they're really targeting is this youngest age kids.
Developmental brain models would support that. If you look at iodine deficiency around the world, certainly periconceptual and early fetal has a much bigger impact on head size, cell number, etc.
Yeah.
Than later. And the older you get, the more reversible it is.
Yeah.
It does look like there is kind of a sense of it.
Yeah.
The other thing I would mention is talk about mutable factors that could change
Mhm.
thyroid status. Joe Prohaska and Brad Anderson, remember who was down here? I don't know if you were here when he was in Kerry Harris's lab. for a
Okay.
while, have been looking at the effect of copper and iron deficiency
Mm.
on
Sure.
thyroid status. Because iron is involved in, I think it's done, it's 2 metabolism.
Mhm.
They can basically show that either copper or iodine deficiency give you, this is an Rhode model, give you the effect of basically giving the baby PTU.
Mhm.
So
Mhm.
at least in rodent, developmentally sensitive rodent models, you need to worry about that. And iron status is all over the
Yeah.
previous, so that's just another factor.
Yeah. Yeah, that really drives home too their physiology and how important that deiodinase 2 activity is, just for the intracerebral higher concentrations of T3 for those critical elements of neurologic development. So great points. Okay, thanks everyone.